Okay, let's start. So we're going to talk about how we can follow up what happens after the treatment and see if patients have responded to the treatment for their myeloma or for their Waldenstrom. Just to remind you that we are talking about a disease that involves either the plasma cells or the lymphocytes, and the plasma cells derive from. Do I have a? Yeah. The plasma cells that come out of the lymphocytes, the B lymphocytes. And then when the B lymphocytes are exposed to antigens or foreign substance, they transform in plasma cells that can make antibodies. They all come from the same place and from the same original stem cell. This is an example of a normal bone marrow. As you can see, there are spaces that are empty. These are fat spaces, and this is very normal in an adult bone marrow. And the rest is a sort of very mixed population of different cells, some larger, some very tiny and very dark. And basically it's a mixture of red cells, white cells, and the bigger ones are the progenitors that make the platelets. This is conversely the aspect of a bone marrow of a patient with multiple myeloma. As you can see, you have lost that mixed heterogeneity of cells, and all the cells, they look very similar to each other. And in fact, all of these are malignant plasma cells. And some of them are bigger, some of them are sort of more traditional plasma cells. And the other important thing is plasma cells are very interesting because they can appear very different. So this is an example of what we call a flaming plasma cell. And these are, as you can see, are plasma cells with the two nuclei. And these plasma cells, they all derive from an original cancerous plasma cell. And their characteristic is that they all produce the same protein. This is an example of the bone marrow of a patient with Waldenstrom. You can see that it's much more mixed. So you have some of the classical Waldenstrom cells, which are sort of in between plasma cells and a lymphocyte. And we've got a few of these here. And then you can have small lymphocytes. And then you can have some instead characteristic plasma cells. So it's more of a mixture of cells. Another characteristic of the patients with myeloma is that they can have bone disease. So another technique that we use to diagnose and then follow up is just doing plain X-rays. And this is an example of a patient who has got myeloma in the skull. Because it's a disease that starts from the marrow, clearly the place where we need to look to make a diagnosis, but also to look after therapy to see if the patient has responded, is to look at the bone marrow. This is what is an example. What is a bone that has been cut? So that is the external part that is very thick. And then when you go inside, it looks like a sponge. And in these sort of holes, that's where the bone marrow stays. So the technique that we use is just to put a needle into the bone and aspirate out of the bone marrow. Aspirate out the bone marrow. And this is an example of the back of your pelvis. This is that's exactly correspond to there, and this is the little area where we go into the bone marrow. In the adult, there are a few areas where the bone marrow is still functioning. One is the sternum, and the other is the back of the hip and the front of the hip. And the one that we most frequently use is the back of the hip. These are the needles that we use to do the bone marrow. This is a shorter needle if you need just to do an aspiration. This is a longer needle when we need to do an aspiration and also to get a little sample of the bone. And that's an example of sort of where the needle goes inside, and that's what we aspirate. And so, as you can see, the bone marrow looks like blood. It's like a thicker blood. Okay. This is an example of a trephine biopsy. So that's the little sample of bone that we get is a little cylinder that we collect inside the needle. Once we've got the bone marrow, what we do, we need to look at it. So in the laboratory, what do we say? We spread the marrow on the slide. So we put a little drop, and then either we squash it in between two slides or we spread it. And so this is what it looks like. These are spreads. We have been spread on and these have been squashed. And then in the laboratory, we stain. So we put some stains so we can then look at the cells. They acquire different colors so we can distinguish. So if you can remember the first slide when I showed the marrow, they have different characteristics. And then we can use the microscope and look at these preparations. As I mentioned before, is the characteristic of both diseases is that the cells, because are neoplastic cancerous cells, they all produce the same type of protein. And the proteins are sort of are immunoglobulins, and they're characterized by a heavy chain and a light chain. So the way to detect the presence of this protein is to either look in the blood or look in the urine. So this is an example of what we find in a normal person when we do an EPG or electrophoresis that separates the protein that are present in the serum. So normally the gamma globulin are here. It's a little bump. And when you've got lots of the cells instead producing a lot of one type of protein, that's you get this peak, which we call the M protein or monoclonal protein. In the urine, normally you don't find anything apart from a small amount of albumin, but because there are these light chains that can be filtered out from the blood into the urine, then you will find the light chains. And we do a 24 hours collection or spot collection, and when we find the light chains, we called Benz-Jones proteinuria, because from the person who discovered this phenomenon. Another important thing is that we are gathering more and more information about the fact that these plasma cells are neoplastic or cancerous plasma cells. And we are discovering more and more chromosomal or genetic abnormalities. So these are some of the chromosomal abnormalities, genetic abnormalities that we are able to test. And we don't use them to monitor disease, but they are important to give sort of help us in prognosis or in understanding which patients are more at risk than the others. The one with the asterisks are the one that is they associated with a poor prognosis. So, in conclusion, is that when, for example, for the myeloma, there are sort of very well-established criteria to categorize the response to treatment. And so there are 3 levels of complete response. So one is the stringent, one is just complete response, and then there is a very good partial response. And basically, these guidelines are to establish this level of response. you need to do a bone marrow biopsy. So we need to look at the presence of how many plasma cells have been left in the bone marrow, and possibly none. So the bone marrow biopsy is one of the tests that is used to establish response to treatment. The other is we look in the blood and the urine for the presence of the M protein to see if it has decreased and if it stays low in a stable manner. And also we do X-ray to see what happens if the patient had bone disease, if the bone has been, the bone disease is being reabsorbed and there is no any more evidence. And clearly also we do routine tests like a full blood count, because if the myeloma is particularly invasive, as you've been told, there is a reduction of the normal marrow, so you can have anemia or thrombocytopenia or low white cell count. So in a patient who has responded, the full blood count will normalize. And also the renal function should be normal. That's all. Questions?
Thank you. Are there questions?
Thank you. I had a bone marrow transplant about a year ago using my own cells. And after the transplant, I ended up with a protein of 1. Now, in the last couple of months, that's gone to a 2. And my last checkup with my specialist, he said none was detected, which he thought was strange. I've got normal light chains. They're quite normal. And I'm wondering, I haven't had any maintenance. As I say, it was nearly a year ago, and I'm wondering what sort of response that would be classified as.
Sounds like this is for an opinion. Would you like me to answer the question? Measuring amount of paraprotein is not an exact science. In fact, Ali, can you go back to that EPG slide? I often have to tell my patients that point. But if it is not detectable, that is a good sign. Basically, no one is going to weigh the amount of protein. So what they do is that using a computer algorithm, they assess that peak and try to tell you the area under the curve. So as a percentage of the whole lot of these different proteins, and then use the percentage on the total amount of protein to get your amount. So effectively, I will argue there is absolutely no difference between the reading of 1 gram per liter versus 2 grams per liter. But with 0, I think it's a good sign. So I think what it means is that you are floating around either none or a very trace amount of protein. So they're all good.
So it can actually go down and then come up again?
When you say come up, don't forget although you say from 1 to 2 is 100%, I think that's a false representation of what's happening. I'm trying to explain to you that the measurement is imprecise. So 0, 1, or 2 are all good. 1 and 2, no difference. 0, I think is good. If I have to choose, I'd rather have 0, 1, and 2. But they're all good results, really.
The normal light chain, that is?
Extremely reassuring. The light chains are a real-time reflection of what's happening in the body. Paraprotein is never real-time because the so-called half-life of paraprotein in the blood and consequently in the urine, because it's filtered through, is weeks, whereas the serum-free light chain is virtually right to the moment. The doctors usually take all the tests together to give you an opinion, not just on one test.
And because the test there is a level of imprecision. So if you repeat the same test on the same sample, you might get once 0%, and you run it again, you might get 1%. So there is not really it is not a significant difference between the two.
In relation to that lady, in 2010, my protein was 23, and I was on a cocktail of thalidomide, chemo and steroids, and it came down to non-detectable, like you said, and at the moment, I think it's bounced up a bit, and if I had seen those things before I've had a bone marrow biopsy, I mightn't have been so blasé having the bone marrow biopsy. But anyway, I'll know at the end of this month whether I've got to go on some more treatment. But I've been off, except for Bonapos, since 2011, end of there. Thank you.
Thank you for the comment. Any other questions?
In the first slide, it said that there's a destruction or it destroys the bone marrow. I sort of wasn't aware of the word destroy. I thought sort of the explosion of the bad plasma was sort of forcing out the good stuff, but I'd never actually seen the word destroy. How does the plasma destroy the bone marrow?
Just go, Kwan.
In fact, holes in the skull have been found in mummies in Egypt. They are holes. Now, as to what happens, the myeloma cells actually stimulate cells that are like the Pac-Man. I don't know whether you're probably old enough to know the Pac-Man. The young people don't, because they didn't go through that. So they go around, literally just eat them out. And in the process, also liberate the calcium into the blood. That's why you get hypercalcemia.
And then when you get rid of the plasma cells, then there is the bone starts to be formed again, and it can patch up. And sometimes that's why at presentation people can have present with a fracture, because there was an area of the bone that is with myeloma. And
so the myeloma cells don't actually do it directly, but via cells called osteoclasts. Clasts are... How would you explain the suffix clast? It destroys things, doesn't it? And osteo is bone. So like iconoclast, you have an osteo-bone clast. No more questions? Yes.
Sorry. Is the paraprotein a good indicator in lieu of a biopsy, or it's not as good as a biopsy, is it, a paraprotein test?
Are you hoping for a no answer?
No, I'm just wondering how good an indicator of paraprotein is, of myeloma progression.
The final arbiter is always a bone marrow biopsy. The final arbiter is always a bone marrow biopsy. And you have to be mindful. When Dr. Bianchi showed you that one piece of trephine biopsy, we have seen instances where only the tip, literally the tip, shows myeloma, which means that if we are 2 millimeters shorter, we would have called it normal. And that's always a problem in assessing myeloma. We call it multiple myeloma for good reason. It's an extremely patchy disease. But as I said earlier on, you always look at the patient and not just numbers, and look at all the parameters you got in front of you. And on a couple of occasions, despite all the measurable parameters looking good, because the patient doesn't, I had to do a bone marrow biopsy and confirm relapse. So occasionally we have to do a bone marrow biopsy. Any other questions? If not, it keeps me fit.
In one of the statements that I think I heard, it said that kinship, it could be passed on through kinship. Is that wrong? Should our children be tested when they're around 50 to see if they've got it in their blood?
We didn't say that, did we?
No.
What was that talk on?
One of the risk factors was the next your nearest relative.
Yes, short answer is no. Don't even do it. Now, was it on myeloma or Waldenstrom's? Well, Waldenstrom's have a much clearer familial clustering than myeloma. In Waldenstrom's, it's about 10% or more of the first-degree relatives that can have a B-cell malignancy. Even then, you are not supposed to do the familial testing. Because at what age? Because you may not get anything until 65. Don't do it. That's an easy question. No more questions? Thank you to Celgene. Free plug. Thank you. Thanks to Dr. Bianchi.